Good evening, Professor. My name is Daniel Chansa. I'm a FNP student at United States University in MSN 572. I am doing integrity check prior to the lung thoracic video. My patient. And there's nothing in my ears. I am doing this video independently, and prior to continuation of the video, I'm gonna place the video so I could have a good view. All right. Prior to beginning, I'm requesting consent from you to continue recording, and after the video to post it on YouTube as Unlisted, so my professor will be able to view the video and assess my skills for assessing lung and thoracic assessment.
Yes.
Thank you. In a real clinical situation, initially knocking on the door, introduce myself. My name is Daniel. I'll be a student nurse practitioner that's doing a lung and thoracic assessment. And go ahead and wash hands and basically explain to the patient every step as we're going forward. Initial step that we're going to do is assessment of the physicality of the contour of the chest. So I'm looking, inspecting, looking at her breathing, the quality of breathing that she's presenting, looking to see if there's any use of accessory muscles. You ask the patient in a real clinical situation to expose the skin so you could be able to physically assess the skin, also looking at the chest itself, the expansion to see if there's any abnormalities such as a barrel chest or frail chest. And in this case, patient presents to be stable without any distress breathing wise. And the next step is to also inspect the posterior of the chest. So once again, I am looking and seeing if there's any use of accessory muscles, if there's any abnormal movements. You're looking at the symmetry of the contour. Also, you're looking at the skin and to see if there's anything abnormal. And in this case, our patient has no abnormal findings. You move on from inspecting to palpation. You're going to palpate the anterior lung fields, beginning with anterior upper lung fields above the clavicle area. And you observing to see if there's any discomfort, and patient would let you know they're grimacing, or they could verbalize that they're having some discomfort. And you're also seeing if there's any trapped air in the subcutaneous tissues or any abnormalities. After palpating the front, the anterior chest, we're going to palpate the posterior chest. Once again, we're beginning with upper lung fields above the scapula in the posterior clavicle area. You avoid the scapular and go underneath. You palpate, also feeling if there's any air that's trapped in the subcutaneous tissue, or if there's any discomfort or pain that patient is enduring during the palpation of the exam. The next step will be to auscultate. Beginning with the front, you want to have a systematic way of auscultating. And I'm gonna begin by auscultating the upper lung fields, the anterior of the chest, above the clavicle area. And in this area, when you auscultate, you could hear the vascular sounds of the trachea area. And if patients has a large breast, you'd have them, or men, if they have breasts, you request that they help you to lift them up so you can be able to place your scope in the right landmarks. After auscultating the anterior, we're going to auscultate the posterior now. Once again, we are beginning with the upper lung fields. And you bypass the scapular and go under. You're auscultating you should have clear sounds to auscultation. There's no abnormal findings in the patient posteriorly. After auscultation, we're going to percuss, and we'll begin with the anterior chest above the clavicle, upper lung fields, and we should have a nice resonant sound because of air that's in the lungs. If there's fluid, you're going to have a dull sound coming out. And it's all resonant, so no abnormal findings. And we're going to percuss in the posterior chest. Once again, striking the middle finger, the DIP distal of my non-dominant hand, and resonance in all lung fields. After percussing, we're going to run some tests. If a patient was having some consolidation or have pneumonia or anything of that nature, you will do voice transmission with firmitus. That one we're gonna feel vibration in the palm of my hand. So I can do the anterior first. Ask patient to say 99.
99, 99, 99, 99, 99, 99, 99.
All right. So I can feel the vibration. If there's any differences between the two sides, then that's indicative of resonance indicative of consolidation in the lung fields. When turning, we're going to do a tactile firmitus in the posterior. Go ahead and say 99.
99, 99, 99, 99, 99, 99, 99.
All right, thank you. And now this bilateral front and back, you could feel the vibrations. If there's any difference in the symmetry, you'd want to follow up and do further workups. After the tactile firmitus, we can do what is called diaphragmatic excursion. And what that is, in the back here, want to find resonance first when patient inhales and holds. And then when they exhale and hold, you as you percuss, you find a dull sound, and that measurement should be 3 to 6 for the normal range, and athletes and those who are well conditioned can go up to 7 or 8. So as patient, take a deep breath in and hold, and then you start percussing until you find a resonance. So you put a marker there, and then you do the same on this side. So you put the marker there, then ask patient to breathe out, and a couple of deep breaths in, and out, and in, and out, and hold. And you can start from here, and then you percuss going up. And once you find that dull sound now, you can measure the two, and it should be equal on both sides. And that is the movement of the diaphragm while patient is inhaling and exhaling. That's how far the diaphragm is moving. And that is diaphragmatic excursion. All right, then we're gonna do some voice tests, voice transmission tests. And the first one is bronchophony, and I will begin with the anterior and ask my patient to say 99, and I'm going to auscultate, listen as she says 99, and if I hear 99 very clear, that is indicative of consolidation in the lung fields. What I should be hearing is muffled sounds when she says 99. Once I place my scope, just say 99, and I move it. When you feel it, go 99 till we
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
All right, and now we'll do the same in the posterior. So once you feel my scope again, you can say 99, beginning with the upper posterior lung fields.
99, 99, 99, 99, 99, 99, 99, 99, 99.
All right, and you can feel the lobes on the right middle by looking, placing your scope on the lateral side of the patient on the right side. And now we can do the whisper paterqui exam, and then this one you tell patient to verbalize whisper 1 to 3, and you shouldn't be able to hear while you auscultate. If you hear that, it's indicative of consolidation, because sound moves more direct when there's consolidation going on in the lungs. So you say 1, 2, 3, you whisper that, and then I'll move my scope and you can do the same. All right, so I was unable to hear anything. That means those are normal findings, and I'll ask my patient to turn so he could do the same in the posterior, beginning with the upper lung fields. All right, so I didn't hear anything, so that's indicative of normal findings. And next, you'd ask patient, would do the egophony, where patient is going to say E, and while I'm auscultating, if I hear ah, so that changes from E to ah, that's indicative that there's consolidation, because you should be hearing E as clear as it comes out. So we'll begin with the anterior chest, the upper lung fields.
E, 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 E.
Okay, so we'll do the egophony on the posterior now. Say E, once I move my scope.
E, 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 E.
All right, And now we would like to assess the chest expansion to see if it's symmetric. So I'll place both my thumbs in the center of the spinal area and kind of push together. And once patient breathes, we should have some kind of motion outward that's symmetric and back. If you have one going further than the other, those are indicative signs of consolidation or something abnormal going on with the respiratory. So you want to find your 10th rib area, and then you want to push a little bit closer, and then ask the patient to take a deep breath. Breathe out, breathe in, breathe out. And this symmetrical expansion of the chest, and that's how you measure that one. And that concludes the assessment of thoracic and lung fields. Thank you for your time.